Okay, you quickly touched on heart disease, damage to vasculature, and coming back to, again, you being a cardiologist, this is your bread and butter. Let's talk about more detail in this realm. Somebody that's becoming metabolically unhealthy, why this is going to increase risk for things like heart attack and stroke.
So one thing is, as insulin increases, as metabolic health worsens, it can affect like blood pressure. That's a perfect example. Your body tends to retain more fluid and sodium in that standpoint, and more adipose tissue, is associated with higher blood pressure. Those go in conjunction with each other frequently, and higher blood pressure is going to increase that stress on the arteries with every beat of the heart. If it's pumping out at 160 millimeters of mercury in the vessel as opposed to 110, that's a big difference for every single time your heart beats and every single time the blood goes through your vessels. So that's going to create an environment where there can be more damage done to the blood vessels. We also, I mentioned about the glycated end products, the glucose being on the proteins. Well, if that's on the vessel wall, that can help injure the endothelium and have the endothelium, the inner lining of the blood vessel, not function as well. So combine that with the increased stress, and all of a sudden you've got more trauma on the vessel wall. So that's certainly one example of how it can happen. Throw inflammation, chronic inflammation on top of that, and you've got yourself a good nidus for developing atherosclerosis. Now, would I pretend to know every mechanism? No. There are probably others, and as common as heart disease is, it actually is interesting to recognize that we don't really know everything about how plaque forms and all the different factors that are in play. Certainly we know a lot, but not everything.
Let's bring LDL into the picture, because as somebody goes lower carb, traditionally, if not always, LDL tends to go up, at least for a period of time. How do you look at LDL when it comes to heart disease?
Well, first I would push back about saying traditionally, if not always, it goes up, because it actually usually does not go up. The literature that looks at ketogenic interventions for type 2 diabetes and for weight loss is pretty clear that on average, LDL does not change. And I think that's really important. Now, there is a subset of people, usually who are leaner, fitter, more metabolically healthy, where LDL will go up. But that's the exception, not the rule. And the majority of people, LDL does not change. And instead, you see HDL go up, you see triglycerides go down, obviously blood sugar and insulin go down, inflammatory markers go down. So you usually see a significant improvement in labs, including lipids. And that's something that I think is really important, because there's this assumption that LDL goes up. Even if it's a high saturated fat, low carb diet, it doesn't mean it's going to affect LDL. But if LDL does go up, then it's something that needs to be taken individually. It can mean different things for different people. But I think the key is that LDL is a relatively poor predictor of the presence of plaque in heart disease. The best predictor is the presence of plaque and heart disease, right? We can actually measure whether or not you have plaque. We don't need to use LDL as a surrogate. So for me, in my practice, when I see patients who are low carb, or if they're keto and they have high LDL, my first question is, do you have heart disease? Let's get a calcium score. Or if that's a little abnormal, maybe a CT angiogram. There are so many better tests we can do, carotid ultrasounds, CIMTs, so many better tests we can do to look for the presence of vascular disease rather than looking at LDL. LDL is not the disease. The disease is plaque in your vessels. So can higher LDL increase that risk? Yes, in large population studies of the general population, there is a small increased risk. Not nearly as big as type 2 diabetes or even markers of insulin resistance, but there is a small increased risk. But that does not mean you're going to get it. Even if you look at, familial hypercholesterolemia, a genetic disorder that people are born with, where their LDL receptors don't work as well, and their LDL levels are very high in the 200s or even 300s for the majority of their lives. You would think that would be a 100% death sentence, the way we talk about LDL, but it's not. It's not. There is you could say in some studies up to half of people do not even get any vascular disease. Well, how's that possible with LDLs that high if LDL is the causative factor of vascular disease? So there's definitely more to the story. And certainly when you talk about people who are metabolically healthy and in ketosis, we are now learning that that is a very unique situation that probably deserves to be evaluated as such, right? Not evaluated the same as everybody else. And this is where, citizen scientist and engineer Dave Feldman and his colleagues, Dr. Matt Budoff, Dr. Nick Norowitz, and Dr. Adrian Sotomoto, who have published in the medical literature quite a bit about this topic, is really helping us sort of reframe how we see LDL, especially within the context of metabolic health and with a reason for that LDL being elevated. If you're in ketosis and need to traffic more fatty acids for fuel, that can lead to a rise in LDL. So it's saying, oh, wait a second, the mechanism is different. The baseline condition and metabolic health is different. The vascular health is different. Maybe we shouldn't see it the same. So that's sort of a long-winded answer to your short question about how I see LDL.
Well, it's interesting you brought up the fact that it's not common for LDL to go up. I thought that was pretty common knowledge in our world that that is going to happen. And to arm people with that knowledge, if they go get blood tests done with their conventional doctor, that this can be a normal response to that dietary change. So this is news to me.
Yeah. I mean, if you look at a number of different published studies and even meta-analyses, most of them show on average no change in LDL. And there was one that actually showed a reduction in LDL particle number. Now, those tend to be the studies that are treating type 2 diabetes or using ketosis for weight loss. When you're talking about thinner, metabolically healthy individuals, that's where you're more likely to see the rise in LDL. So there is a difference based on who you're looking at. And again, Dr. Adrian Sotomoto published a paper looking at a number of these studies showing that the rise in LDL correlated with body mass index and really didn't correlate with saturated fat intake nearly as much, which is, again, sort of surprising because a lot of people think you eat saturated fat, your LDL will go up, period, end of story. And that is not the case. But that is what's believed by a number of people in mainstream medicine. And nothing really bothers me more than somebody saying either you shouldn't start a ketogenic diet because your LDL could go up. Well, why don't you just test it and find out if it goes up, right? It's not like this is a big secret. You can do it 4 months, 6 months, a year, whatever, and test it. Or someone would say, no, the risks outweigh the benefits. Well, what risks? Like you can test somebody for the risks, and what benefits are you even talking about? Are you talking about somebody putting their treatment-resistant bipolar disorder into remission where nothing else worked, or somebody putting their type 2 diabetes into remission where, they were on multiple medications before? Like, what benefits are you talking about? And what theoretical risks are you talking about that you can't measure and follow to see how they change? So those are two things that really bother me about how mainstream medicine sort of talks about ketogenic interventions.
Yeah, riffing off of what you just said there, it's like, for one, does LDL actually go up? And then two, does it actually matter if it does go up? And we need to ask these questions.
Yeah. I mean, there's a documentary that will be coming out called Cholesterol Code. And it's about sort of this concept, about this study that Dave Feldman and Dr. Matt Budoff and others are doing. But the documentary isn't just about the science, because that is important. What happens to individuals if their LDL goes up? Can we measure whether or not their plaque and their arteries increase? But also about the personal stories about the people who are transforming their lives with ketogenic intervention. So then how do you factor this in? And you absolutely should not take someone who has changed their life with this type of intervention and be like, oh, but your LDL could go up, so you probably shouldn't do it. To me, that's just not medicine. That's not taking care of the person in front of you.
And to add some detail to what you just said there about Dave Feldman and his buddies there, we're talking about lean mass hyperresponders. And when I was asking you about LDL going up in a general sense, that wasn't what I was talking about.
Yeah.
But you've clearly defined both now.
Yeah, good point. So you can get small rises in your LDL of, 10%, 15%. Again, on average, there's no change, but some people will see small increases. But what a lot of people think about, certainly where my brain goes when you talk about LDL rising, is this very small subset of people where it dramatically goes up, where you're maybe at 120 before and now you're at 280 for LDL, right? That's a huge jump. And that freaks a lot of people out. Understandably, it can be very nerve-wracking for a patient and for a physician. And that's what this That's what this documentary and this study is looking at, because if you want to really investigate the impact this has, it's going to be hard to investigate the impact if your LDL goes from 120 to 150. Okay, that's an increase, but what kind of impact is that going to have? But if it goes from 120 to 280, that's a dramatic change. And that's the levels that we would think would cause rapid vascular damage, rapid plaque accumulation if LDL by itself was the concern. So, I mean, it's the perfect subset to sort of study this and answer the question. So yes, that's what Dave Feldman and Dr. Matt Budoff and others are studying. But then you can look at the study published by Virta Health. This was back in 2018. I think they published a study about their 1-year results of using a ketogenic diet to treat people with type 2 diabetes. And they found on average LDL went up by 10%. But the ApoB, apolipoprotein B, which is you could think of as just a better LDL. It's a more predictive marker than LDL itself. ApoB did not change at all. And when you see metabolic health improving like that, you're going to get rid of some of the small, dense LDL. You're going to have more of the larger LDL. So that's how LDL in total can go up a little bit. But ApoB, or the number of LDL particles, isn't going to change. So LDL doesn't tell the whole story. And when you calculate their cardiovascular risk, it actually went down by 12%. So LDL went up by 10%, but cardiac risk, calculated risk, went down by 12%. And a lot of that has to do with improved metabolic health and the ApoB not changing. So yeah, we have to differentiate just small increases from the lean mass hyperresponder. But also, if you're talking about the LDL itself going up, you want to dig a little bit deeper and say, what does ApoB do, or what do your small LDL particles do, and what's your metabolic health doing? Because those are better predictors of cardiovascular risk than just LDL cholesterol.
All right, let's talk more about this subset of LDL, the different pieces, the small, dense, large, fluffy. We have oxidized LDL. For you as a practitioner, and then as somebody listening as a patient, how valuable is that deeper data?
Yeah, I mean, look, I think it's incredibly valuable. I think LDL by itself is not very helpful. Certainly, you want to interpret LDL in context of your triglycerides and HDL and your metabolic health. But knowing if your LDL is mostly small, dense LDL or larger LDL is helpful. Now, it's not an absolute. And I think that's where we can sometimes get into trouble. If someone says, oh, my LDL is large, I don't need to worry about it. Well, if you've got plaque, if you've got existing heart disease and your LDL is large, I would still be concerned about it. But if you have 0 plaque, calcium score is 0, no plaque on CT angiogram, you're metabolically healthy, and you have almost no small dense LDL, that's a situation that I'm a little less concerned about. And then you mentioned oxidized LDL, same thing. I mean, oxidized LDL, or the LDL that's really inflamed and oxidized, that's the one that's going to cause the damage. That's the one that's going to cause the plaque, especially sort of the angry, inflamed, aggressive plaques that can break off and cause heart disease or cause heart attacks. So that's the other part of the cholesterol you want to worry about. And that speaks a lot to sort of the environment in which the cholesterol lives. Is it a high oxidized, high inflammatory environment, which happens with insulin resistance and metabolic dysfunction? Or is it a low oxidized and low inflammatory environment when someone who's metabolically healthy and living a very healthy lifestyle? So those things definitely make a difference. But again, not part of the standard medical tests. And you can kind of infer from standard medical tests about that. If your triglyceride to HDL ratio is very good, you're less likely to have small dense LDL. If your high sensitivity CRP, which is a sensitive inflammatory marker, is good, you're less likely to have oxidized LDL, but nothing's 100%. It's all sort of a best guess based on those tests, but the tests are available and you can do them. And one of the things that's really cool now that didn't exist so much 10 years ago is people can get their own test. You got to pay cash for it rather than using insurance. But if your doctor's not, interested in getting these tests or doesn't understand these tests, there are websites out there, ownyourlabs.com and others, where you can get these blood tests done on your own. It just unfortunately takes money.
If somebody wants to do that and be really comprehensive and they're on their own, what are the minimal tests they want to get done to have a comprehensive view of their heart disease risk?
Yeah. And here the terminology is tricky because Quest is different than LabCorp, is different than Boston Heart, and so forth. They all kind of have their own thing. But basically, you want some sort of advanced lipoprotein testing, and that sort of encompasses this, small particles, large particles, HDL particles, and then some marker of inflammation, whether it's the CRP or a test called a PLA2. Or just an oxidized LDL test. And then tests of insulin resistance, like we mentioned before, the fasting insulin. Those are sort of basic places to start, and you can always dig deeper. And that's one of the things that Own Your Labs has done is they've put together sort of these packages depending on what you're looking at. So they're sort of like prearranged packages for the ultimate heart disease test or the base heart disease test. I forget exactly what they call them. I haven't looked at it in a while, but it's nice to have that sort of structure and that guidance.
All right, let's move deeper into plaque. Somebody that wants to get a visual on what's happening in the arteries, what's the best test? And then I know there's soft plaque, hard plaque. Let's differentiate there and talk about what's more dangerous.
Yeah. So when you're talking about hard arteries, the basic test that pretty much anybody can get is a calcium score. That is a CT scan. It takes about 10 seconds. Your entire appointment probably takes about 10 minutes. It's relatively low radiation. It's about 1 millisievert. And for reference, a mammogram is about 0.5 millisieverts. And just living on Earth at sea level by the equator for a year is 3 millisieverts. So it's 1 millisievert, and it tells you whether you have calcium in your arteries. And that is a very good start. Certainly if the answer is 0, if the score is 0, that you don't have any calcium in your arteries, studies have shown that you have a very low risk for having a heart attack over the next 10 years. It's not 0, and that's, everybody can point to one study that says, look, this person had a 0 score and had a heart attack. It happens, but it happens with normal LDL too, right? And people sort of forget to point that one out. But it's very, very good. Now, if it's elevated, it's a different story. And this is where, even though it's a good test, it's sort of a blunt test because it doesn't tell you anything about soft plaque. It doesn't tell you anything about when the plaque was developed or why it was developed. So some people can use calcium scores to follow over time to see if you're developing more plaque over time. Again, it's a bit of a blunt instrument. The better test is a coronary CT angiogram, but this is much more involved. So whereas a calcium score, if you have to pay for it yourself, is about $100. Some places maybe $75, some places $150, it varies. CT angiogram is very different. That's about $1,500 if you have to pay for it, right? So much different. Instead of 1 millisievert, now we're talking about 3, maybe 4 millisieverts. Now we're talking about IV contrast and iodine-based contrast that's injected into your vein. The whole appointment now is maybe an hour and a half. You have to regulate your heart rate, right? So you can see just by me talking about it, it's a much more involved test. But because of that, you get much better results. You actually see the arteries themselves. You see inside the arteries, not just the silhouette or the walls of the arteries. You see if there's soft plaque. You see if there's calcified plaque. You can see exactly where it is. You can see if there's any narrowings. So it's a much more advanced test. And now there's a company called Clearly. There may be others soon, but right now Clearly kind of has the corner on the market here that does an additional evaluation on those scans where it can tell you, it can actually quantify how much calcified, how much non-calcified, and how much low density plaque, which is really the highest risk plaque. It can quantify that, show you exactly where it is on your arteries. And now you know, and you can say, okay, so here I am at time 0, and this is what I'm going to do to treat this, whether it's a medication, whether it's a diet, whether it's a exercise program, a supplement, a combination of all those, whatever. And now I have an objective measure to say, am I making progress, right? Am I causing regression? Am I halting progression? Or is it still rapidly progressing despite what I'm doing? That is so important. That's the information everybody needs. Unfortunately, it's not available for everybody. But gosh, when I use this with patients in my practice, it is just, it's mind-blowing how precise, how specific, how much information we can get from that test. And I wish it was widely available to everybody.
Okay, you say everybody, but what about somebody who is metabolically healthy? I want to get an idea of prevention. I know you're really big on prevention. Somebody who's middle aged, they're normal weight, they feel like they're metabolically healthy. We've talked about blood. We've talked about now looking at the arteries. What would you say somebody would want to do preventatively to see where they're at? And then how
Yeah.
often would they want to monitor?
Yeah, I mean, because somebody's metabolically healthy now doesn't mean they always were metabolically healthy as well. So it depends on, how old they are and what their lifestyle was like before. That's all really important. But a calcium score is the place to start. And hopefully the calcium score will be 0. And then it's also age based. A calcium score of 0 at age 40 has a different prognostic factor than a calcium score of 0 at age 60, right? It's much more powerful at age 60 to have that 0 than age 40 to have that 0. So how often you're going to check, depends on what you're doing and what are the risk factors you have and how old you are. So if you have a 0 at 40, maybe you check it 5 years later, right? If you have a 0 at 60, I don't know, maybe you check it 10 years later. Now, if it's not 0, and you want to, then you're going to want to follow it more closely. And again, it's hard to give general recommendations because it depends on the age and the score and what you're doing differently. Some people check them every year. Some people will check every year until sort of you see some sort of stability or a very slow progression, and then space it out to every 2 or 3 years. There are lots of different options there, but I think the calcium score is the place to go. Dr. Matt Budoff, who's one of the, I guess you can call him one of the forefathers of calcium scores, has referred to it as the mammogram of the heart. You don't think twice about getting a mammogram just about every year for most average women. So he would say you shouldn't think twice about getting a calcium score every year or every other year for most average people. That hasn't quite caught on, but it's an interesting concept because it's such a better measure than an LDL blood test. Because I said it before and I'll say it again. LDL is not the disease. Heart disease is the disease.
For somebody that has testing done, they see that they have plaque buildup. What do they do at that point? They decide to take on what we're going to get into today, become more metabolically healthy. What hope do they have to reverse that plaque?
Yeah.
Or is it just about maintenance at that point?
Well, I like that you said they're going to become more metabolically healthy because often what happens is, the discussion goes, oh, your calcium score is 50, 100, 200, whatever it is. Here's your statin prescription. And I like how you said it. They decide to become metabolically healthy because the discussion should go, you have, calcium in your arteries. Let's make sure we have a very, very thorough test of your metabolic health. And let's make sure we improve that significantly. Then maybe a statin or maybe treating LDL is part of the discussion, but it's not the only discussion. Metabolic health is first and foremost. But there are studies, again, in the general population that show if your calcium score is above 100 and you put half the people on a statin, half the people not on a statin, or actually, let me rephrase that. It was an observational study, but for people whose LDL was above 100 and those who went on a statin versus those who didn't, those who went on a statin had a small decreased risk of heart attacks. Now, if the calcium score was 0, there was absolutely no difference 10 years later. But if the calcium score was above 100, there was a small benefit to being on a statin. So that's where treating lipids can certainly come in to be part of the picture because there's something about having plaque that begets more plaque, or something about having plaque that provides the nidus for LDL to then become a little more detrimental. But if there's no plaque, it's a different story. So I think that's important. Now, how does metabolic health factor into that? That's what hasn't been studied because whenever you're studying the general population and the intervention is a statin prescription, not improving metabolic health, you can assume that you're dealing with a metabolically unhealthy population at baseline. So will metabolic health change that? It's certainly possible. And I think it's actually probable, but we don't have the strong data to point to that. We can look back and say, okay, if we look at triglycerides and HDL in these old studies, it seems to be a little more protective or have less of a benefit of treating with medications or less of a risk if your triglyceride to HDL ratio is better. But that's different than saying, okay, we're going to design the study moving forward to look at that. Those studies aren't really powered to look at that, but it's certainly suggestive, So, that's where you really got to work with your physician and say, like, look, I am metabolically healthy. Here are my tests. Here's my lifestyle. And yes, I have plaque, but that could have been, deposited before. So does it mean I actually need a prescription for a medication, or does it mean we can follow this moving forward to see if there's progression, to see if there's regression? So you brought up that term regression. And this is another tricky one. Because when you talk about regression, like I don't believe regression of a calcium score is really the main goal. Because if you have soft plaque that you turn into calcified plaque, that's actually a good thing, right? Because calcified plaque is more stable and less likely to rupture and cause a heart attack than soft plaque. So that's actually a good thing. But the calcium score is going to go up, which is kind of thought of as a bad thing, right? So it gets a little more complicated. So again, this is where I really like CT angiograms. So when you talk about a CT angiogram with an objective plaque analysis, like with the Clearly scan, that's where you can really measure regression. Again, it's not a test that anybody can get, unfortunately, but that's how you measure regression. So that's the only place I would really talk about regression. When you're talking about calcium scores, I wouldn't talk about regression. I would talk about slow progression or lack of progression, or trying to make sure there are no new areas of plaque. Those are a little more nuanced interpretations. But yeah, when people, there are cases online and people say their calcium score regressed or went to zero. A lot of the times that might be technical issues. A lot of the times it may actually be true, but I think that's too high of a bar to set for the average person and may not be the right goal.
So we know metabolic health is connected to heart disease. As a cardiologist, how often would you see somebody come to see you who's been metabolically healthy, is currently metabolically healthy, but yet still has plaque building up? Mm-hmm. How definite is that connection?
So they were metabolically healthy, they've been metabolically healthy for years and years and years, and now have plaque, or they were previously not metabolically healthy? Sorry, I want to make sure.
Basically, other risk factors have come in, say it's smoking or fried foods. I'm just making these up, but basically, can you assume when you see that plaque that somebody is metabolically unhealthy or they've been metabolically unhealthy?
Yeah, so that's tough. Yeah, I mean, it's probably the most common risk factor, but sure, you also get people who smoked, a pack or two a day in their 20s or 30s, and now come to you with plaque in their 40s, and smoking tobacco is a huge risk factor. Or someone who's got a really strong family history, and that's something that is unfortunate. If your dad had an MI in his 40s, you might have the deck stacked against you, and maybe you're going to develop plaque in your 50s if you're perfectly healthy, otherwise healthy, whereas you would have done it in your 40s before if you weren't so metabolically healthy, right? So you do have to weigh all those other risk factors. And that's part of the frustration. A lot of times patients come to me and they say, I want to know why I have plaque in my arteries. I'm like, well, you can't always say exactly why. Did you smoke? Do you have a family history? Did you used to have high blood pressure? Did you used to be metabolically unhealthy? There are lots of things that you have to guess at someone's past. But those tend to be the big risk factors, right? Especially blood pressure, especially metabolic dysfunction and hyperinsulinemia, and especially family history.
If you enjoyed that clip, you're going to want to head over here and catch the full episode. I'll see you over there.
Metabolic dysfunction for a lot of doctors, and certainly the way I was trained, is whether or not you have type 2 diabetes. And if you're short of that, you're okay. Metabolic dysfunction, being metabolically unhealthy, starts at that early stage of insulin resistance when your body